Hi, this is Brian Kim. I want to share with you this case of a patient who had ectopia lentis, and the retinal surgeon took out the lens and performed vitrectomy. And so now the patient's left aphakic, and I'm going to perform the Yamane technique using my modified technique, which improves ease and maximizes refractive outcomes with the Sensar AR40 lens. Now, mind you, this is going to be a completely unedited video. And I'm going to share with you why my technique, especially when it comes to the Sensar AR40 lens, I'm able to minimize any unnecessary stress on these delicate PMMA haptics. So you can see this is the eye. You can see that the patient's aphakic, has had a vitrectomy as well as had a PI. This is the left eye. I'm sitting supratemporally. Drying the surface of the eye, and then I'm inking the tip of a 27 gauge cannula. Inking the limbus on the right side using that 27 gauge cannula, finding 180 degrees apart using the shaft of that cannula, and inking the limbus on the left side in similar fashion. This is the fixed caliper by Epsilon. Again, I don't have any financial interest. I'm indenting the sclera 2.5 millimeters posterior to that indentation, and then 2 millimeters adjacent to that. Making sure it's nice and dry, once again, with the Wexel sponge, and then inking those indentations with the 27 gauge cannula. Performing the same thing on the left side. And again, this is a completely unedited video, so I'm going to just show you all the things that I do. Again, there's obviously situations where you have to go back and ink it again, and you want to have nice, distinct ink marks. You don't want to have any smudges. And remember, placing the needle through the sclera is the single most important part of executing the surgery well, because remember, just getting a good anatomic result is not enough. You have to have a good refractive result, and the only way you can get a good refractive result is if you have the needle passed through the sclera 2 millimeters or so, which creates a nice scleral support for the lens, which best mimics the in-the-bag IOL placement. Now that I've made my marks, which again are nice and symmetric and even, again perpendicular to the limbus on either side, I'm going to make my incisions. This first incision is for the AC maintainer. This contralateral incision is to externalize the leading haptic. And again, because I don't have a lens, I really don't need any additional incisions. This incision is just to help me place the viscoelastic in the eye, and also for me to do any vitrectomy if I have to do it. This is intracameral epinephrine. And this is dispersive viscoelastic. Of course, this patient's aphakic. I'm not quite sure how much of that viscoelastic will stay in the anterior chamber and coat the corneal endothelium, but it's still worth a try doing this. And this is the 3 millimeter blade. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then I enter. This is a 25 gauge needle. You can see there's already BSS mounted on a 1cc syringe, and I'm bending it fairly close to the tip, and I'm bending it so the bevel is facing to the right. This is the right side needle. I'm bending the needle about 9 millimeters from the tip, making sure that the bevel is going to face the main incision, and this is the left side needle. This bent so that the bevel is facing towards the contralateral limbal incision. Again, all of these needles are mounted with 1cc syringe of BSS. You want to make sure you prime the needle so you don't have any bubbles. Now I'm asking for the cartridge. This is the emerald cartridge for the J&J AR40 Sensar lens. Pushing cohesive viscoelastic to fill the barrel and the platform as well. Placing the lens onto the platform, making sure that the optic is seated Within the wings, you can see I'm going to do a side-to-side jiggle, which again, it feels nice and smooth and it ensures that you're in the proper position. Bending the wings together, making sure the optic bends backward, the leading haptic straightens out through the barrel, and the trailing haptic comes out to the back end. Placing the cartridge into the injector and making sure that the trailing haptic is up outside of the barrel when I advance the plunger. Now I'm ready to go with the 25 gauge needle in my left hand. I place it through the contralateral limbal incision. The injector goes through the main incision. Both bevels are facing each other. The needle to the right and the injector to the left. My assistant advances the lens. I'm able to dock the haptic on the bevel of the needle. As she advances the lens more of that haptic is internalized into the needle through a passive technique. And then I withdraw the needle and the haptic comes out. I take over and make sure that the optic comes out planar, and then the trailing haptic is swept to the right. Remember, this patient's had vitrectomy, so I have not had to do any infusion. I haven't had to make any pars plana trocar incisions. So here is the AC maintainer. This is a 22 gauge thin-walled AC maintainer. Again, I don't have any financial interests. Once the lens is in, I place that AC maintainer in place. And why is that? Because when I stab the needle through the sclera, the eye has to be firm. If the eye is soft, then you're going to have improper placement of those needles through the sclera. You have to fix the eye in the neutral position, have a nice firm globe, having discrete and distinct marks as I've shown. I'm going to pull the leading haptic out more. This pushes the optic away from me, and this gives me much better access to the trailing haptic without damaging or bending the haptics. Again, with the Sensar lens, the haptics are PMMA, and you want to be really, really delicate. And this maneuver, externalizing the leading haptic through the contralateral limbal incision, really limits how much tension there is on the haptics. So this is the right side needle. I'm going to hold the eye, the sclera, with opposing forces on the other side. I stab the conjunctiva and sclera with the needle. I flatten out, turn on infusion, tunnel 2 millimeters. I didn't feel comfortable, so I start again. I release, I stab, stay nice and flat, tunnel 2 millimeters, holding the eye with opposing force. Again, I didn't feel comfortable, and why is that? This patient's a super high myope, and the sclera is very, very thin. So I did that multiple times because I wasn't quite comfortable, and again, I'm thinking, is it because I have a premature entry into the sclera? And the answer is no. This patient just has really thin sclera because of her condition with the ectopia lentis, high myopia. So I tunneled one last time, and I felt pretty confident that this is the right angle. Again, I stayed really, really flat to the sclera, near parallel to the scleral surface as I tunneled 2 millimeters and then dove down. You can see here I pulled the leading haptic out more, which again pushes the optic away and gives me excellent access to dock the trailing haptic into the right side needle. You saw 2 pushes is all I did, and I was ready to go. Again, I was able to approach, fortunately, nice and parallel without much difficulty. Disengaging the needle from the syringe. And then I'll internalize the leading haptic with smooth microforceps. Remember, with the 30 gauge thin-walled needle and the PMMA haptics of the AR40 lens, it's a very snug fit. And that's because the PMMA material is more tacky, but also the diameter of this haptic is a little bit bigger than the C2 Lucia, and it does not slip. I promise you, it will not slip even if you only have 2 pushes, which again is about 1.5 millimeters. Holding the eye contra-incisionally for opposing force, I'm stabbing the conjunctiva and sclera at the first mark, flatten out, tunneling 2 millimeters through the sclera, and then I dive down. Again, the eye is infused. It's a nice firm globe when I pass the needle through the sclera. Grasping the haptic, turning the needle towards the haptic and not the other way around. Dock the haptic on the bevel of the needle, 2 pushes, and then I'm in. Pulling both needles out a little bit, and then withdrawing the left side needle, pulling it towards me, limiting how much haptic comes outside the eye. By limiting how much haptic comes out, you're going to limit how much stress is on the optic-haptic junction. And that's why it's really advantageous to use the Sensar lens because, like I said, the 30 gauge thin wall needle grips that haptic so well. Remember, when you internalize too much haptic into the needle, that does cause tremendous stress on the opposing optic-haptic junction, which was more of a problem with the C2 Lucia. And why? Because in my experience, the C2 Lucia tend to slip out of the 30 gauge thin-walled needle. Again, it's a double-edged sword. Of course, with the C2 Lucia, it was much easier to execute because the haptics were stronger and the haptic also had a smaller diameter. It can slip in better. But because of the smaller diameter, it really could slip into the eye while you're doing the externalization of the needle. You can see I'm limiting how much haptic comes out on the right side needle by pushing the haptic into the eye as I do this, and this limits any undue stress on the optic-haptic junction. Cauterize the tip, and then I am done. Pushing the haptic flush to the sclera, embedding the flange into the sclera and burying it deep, reapproximating the conjunctiva, and again, a well-centered lens. But more important than centration is really with minimal tilt. Why? Because I tunnel 2 millimeters, I'm going to have a nice scleral shelf, very good support for the lens, which most mimics an in-the-bag IOL placement. Therefore, you're going to have excellent refractive results with your Yamane technique. This is the 10-0 nylon suture. You did see that I did edit that one part, so not quite 100% honest when I said this is an unedited case, but it is unedited in the sense that all of the most important aspects of the surgery were unedited. This is just the very end when I'm placing the suture in. I didn't want to bore you when my surgical technician had to grab me the suture and we were waiting on the suture. And so I'm going to go ahead and close the main incision with a 10-0 nylon suture. I always do this because I don't want to have any potential vitreous come to the wound. And by doing this, I have not had that situation, fortunately. Go ahead and cut the needle and then bury the knot. But you can see well-centered lens. I don't have to make a surgical PI because there's already a large PI that the retinal surgeon put in. And I didn't put in the AC maintainer until the very end when it was time to execute the scleral needle placement for the Yamane technique. You want to have high infusion pressure when you're stabbing the sclera with the needles. I was able to do all those previous maneuvers without infusion. I'm pulsing BSS through the paracentesis incision, trying to clear any viscoelastic from the anterior chamber. And then I'll pull out the AC maintainer at the end of the case and I'll hydromat incisions. So again, this is an unedited video of a patient who had ectopia lentis. Again, the retinal surgeon took the lens out. The patient had a lensectomy as well as a pars plana vitrectomy. Interestingly, and I posted this video a while ago, but I did her other eye, actually removed it through an anterior approach, and after I removed the lens through an anterior approach, I performed Yamane technique. And so this patient's had it both ways. Fortunately, the eye that I did ended up pretty good. Her vision is fairly close to plano, a little bit myopic, but very happy with her result. This eye, because she was aphakic, again, because she's a high myope, she's more like a +4, a +3 in this eye. But the anisometropia was really bothering her, and that's why she had a secondary lens put in. Again, by executing the technique like I did, using the Sensar AR40 lens, externalizing the leading haptic using a 25 gauge needle passive docking technique, and then pulling the leading haptic outside the eye, I have much better access to the trailing haptic. Remember, discrete marks are very important. Stabbing the conjugate sclera at the first mark, and then flattening it out and staying near parallel as you tunnel the needle all the way through the sclera 2 millimeters and then diving down towards the optic nerve. And again, turning the needle towards the haptic and not the other way around because the haptics are very delicate, and then docking the haptic on the bevel of the needle. And then if you're aligned in three-dimensional space, you saw how easy I was able to dock it, flatten it out, and then 2 pushes and I was in on both sides. You want to limit how much haptic is internalized into the needle, and then likewise, as you pull the needles out, you want to limit how much haptic comes outside the eye, because more haptic that's outside the eye, that means there's more stress on the optic-haptic junction. I pushed the haptics down, flush to the sclera, placed the tendonal suture. This patient, post-op, day 1, had a 20/40 uncorrected vision, and this is with the suture in place. After I take the suture out, it's possible that that vision will improve even more. So again, you want to focus not only on good anatomical results, but also excellent refractive results with the Yamane technique, and this is all predicated upon excellent planning, discrete marks for your scleral needle placement, making sure you obtain a nice scleral support, a scleral shelf for the lens, which mimics the in-the-bag IOL position. So I hope this was helpful to you, and I thank you for your attention.